Good afternoon, everybody. I hope you're having a spectacular afternoon. Today, we will continue with the webinars of multiple disciplinary workshops on primary care. I'm Francis Lee Sanchez. I will be your moderator today. For those of you who want, we have interpretation services. So to be able to access them, you need to click on the More, then Interpretation, and then click on the corresponding audio that you wish to listen to. These webinars are brought to you thanks to a subvention, a grant given by HRSA and TTOB project with the purpose of connecting specialists with academic medical centers to providers of health services in rural areas. In our general guidelines, you can turn on your cameras. You can also use the chat for any doubt or question throughout the session. I also remind you that this session is being recorded for educational purposes. This is the pre-test. We have the QR code that you can scan. It's also on the chat. You'll see the link, and it'll be also on a pop-up on your screen, so you can go answering these 3 questions. Those of you who are entering now, we are in the pre-test part. You can use the link in the chat or scan the QR code. The pre-test will be open. I will continue because we have a lot to learn and a lot to study. So let's get on with it. Without further ado, for those of you who have been connected with us in this time, you know María Rodríguez, the cardiologist, María Rodríguez. She will be talking about secondary prevention after a myocardial infarction. So, doctor, please. Hello, good afternoon. As was mentioned, I'm Dr. Rodríguez Santiago. I'm in San Patricio Heart Institute, and I'm at your service. So let's start. We're going to divide the format of the presentation in this order. We're going to talk about the antiplatelets that we're going to use, the indications, the combination, the medications to bring down cholesterol, and the rest of the groups, and how you treat them, and how the triglycerides, what they should be, the cardioprotective agents, the anti-anginal strategy, what we want to achieve in our lifestyle and in our. Why is it important to talk about secondary prevention? And it's because these patients who have some kind of cardiovascular event, for example, an infarction, right after hospitalization, and usually in those first 30 days, they have a 6 times higher risk of having another event. And about 50% of those events that are recurrent tend to be within the first 90 days after the first, or within that first year after an infarct. With no secondary prevention, 1 out of 5 people will survive that second cardiovascular event in the first year, and 18% of patients that experience some kind of cardiovascular experience or event recur, they can recur. 18% of patients can recur after that, within that first year. Here, I broke it down in a bit more visual way regarding the timeline, and these are the most important dates that we need to keep in mind. our patient is at a higher risk of recurrent in a cardiovascular event, the first and most important, the first 30 days of that first infarction. The second important point in timeline is the 90 days. So 30 days, 3 months, and within that first year, we have to be extremely aggressive with our patients and have them under observation. You can pass. So, what to do when we get a patient who's had an infarction? Here we're going to see, I'm going to give you the strategies of what is in the guidelines and the way that I myself do it. Okay, first, the antiplatelet therapy. In general, a patient who had an infarction must be in a dual therapy or antiplatelet, or ideally 12 months. A dual antiplatelet therapy means aspirin, an 81 milligram aspirin, plus a P2Y12 inhibitor. Let me explain what P2Y2 inhibitors are. They're the ones that we see there, the ones that we use. There's one that we use intravenously, but the 3 medications that are oral and that are used in everyday in outpatient practice are clopidogrel, which is Plavix. The dose is what you see there, 75 milligrams daily. Prasugrel, which is Efficient, 10 milligrams daily. And if it's adjusted, if the patient weighs less than 60 kilograms, is 50 milligrams daily. And ticagrelor Brilinta, which is 90 milligrams twice daily. Usually in the clinic, we don't have to choose which one we will use because the patients, they've already been discharged from the hospital with one of these antiplatelets. So in order to be able to discharge them, I don't know if at all hospitals, but at least in the ones that I have worked in, they have to have reached the medication and have it, and they must have it in a little bag before being discharged so they don't miss a dose. A question we get often is if the patient is allergic to aspirin, then he stays in a monotherapy of one P2Y12 inhibitor. The photograph that I'm putting there is how the medication works, where the protein is inhibited, the receptor, the ADP is inhibited, of the protein is inhibited, and that stops the aggregation of platelets. So the first important point, as a general point, is dual antiplatelet therapy for 12 months. For me, as a general rule, the younger the patient, the more aggressive I want to be with that antiplatelet therapy, because it's a patient that first tends to be stronger, less fragile, less tendency to bleed, or less probability, but an event that happens earlier has a higher probability of happening again because the life expectancy is bigger, or larger or longer. Okay. So DOACs are direct oral anticoagulation. These are the famous, and we'll see it in the next slide, but here we have the expand, etc. So the patients that don't use them, meaning that are only in antiplatelets, as I said, general rule, 12 months. And this is very important. It doesn't matter if throughout the hospitalization there was a membrane put or it has a stent or not. If he was diagnosed as an index event, an acute coronary event throughout hospitalization, independently of that and putting in the net, the patient must be in that dual therapy for 12 months. That's the first bar that we see. The second one that we see here. Dual therapy of antiplatelets until 12 months, for the first 12 months. And we can extend after 1 year for at least maybe 3 years. Who would I extend the therapy for 3 years? Maybe a man who is 55 years old with stable hemoglobin, no bleeding, good renal function. I want to be a bit more aggressive with that patient, and possibly I will extend the dual therapy for 3 years versus a patient who's 81 years old with some level of renal conditions. So we would have them in dual therapy for 1 year, and then maybe we'll move to aspirin or to the inhibitors. There is a strategy, which is the third bar that you see, in patients that have a high bleeding risk. We can have two basic strategies. Number one is to let the patient in dual therapy for 6 months and then move him or de-escalate the therapy to aspirin, which is the third bar. And the fourth bar, which is the one that we see in yellow, that means that patient is at an extremely high risk of bleeding. So we shorten the therapy of dual antiplatelet therapy to 1 to 3 months. And then after the third month, we move him to a P2Y12 inhibitor therapy. So, for example, if the report of the catheterism has lots of nets, some that are very long, reports that describe that there was some kind of complication throughout the procedure, a small dissection that was then covered with a small net. These are patients that when they have a thrombosis, which are put, and the nets that are put in the bifurcations, they go to a higher risk of ischemia. So we want to be more aggressive with the dual therapy versus patients that are at the other spectrum of high bleeding therapy, that we then shorten the therapy of the dual therapy at least, and we put them then in an antiplatelet therapy. Okay, let's go on. We change the strategies if the patient uses DOACs, which are, again, rivaroxaban, edoxaban, apixaban, and I will show you in a slide so you have them as a reference. The strategy of the patients that use these anticoagulants, the indication can be, for example, atrial fibrillation, embolism, and pulmonary embolism, and so on. If these patients were already in a DOAC and have an acute event or an acute coronary event, the strategy is to leave them in that therapy of the DOAC plus the P2Y12 for 12 months, okay? And the triple therapy, I mean, we have various important points, but the focus I want to do here, a triple therapy of aspirin and P2Y12 and DOAC is not used in very select cases. And that has been in vogue lately in the American College of Cardiology. They've really been speaking about this to the point that you would think that the more medication, the more aggressive we are, the lesser the infarction possibility. But the possibility of reinfarction with a triple therapy versus a DOAC and a P2Y12, you have the same probability for recurrence of ischemia, but those who were in triple therapy had a much higher risk of bleeding. So it was all risk and basically no benefit, I mean, in comparison with a standard therapy. So these patients that have some kind of anticoagulant, you continue with the anticoagulant and you leave the P2Y12. If the patient has an ischemia risk, an ischemic risk that's very high, the most we will leave that triple therapy is 1 month, and that's it, and then we take it away. On the other hand, if the risk of the patient for bleeding, which is the one we have here, the one in the middle, in those patients, we shorten. What we're going to shorten is the DOAC plus the P2Y12 therapy. So we will shorten that time frame from 3 to 6 months. I think she meant 12, but and then we continue with the anticoagulant. So if the patient that already has a atrial fibrillation problem, Then we continue with DOAC and the P2Y12 and for 12 months. And then after the year, it continues, the anticoagulants are continued indefinitely if it is atrial fibrillation. Here is the dosages of the medication that has been approved and the indication for thrombovenosis, but they might be different, but it's the same type of medication. The second pillar, we spoke of the antiplatelets. Now we're going to talk about, I'm summarizing the points. The year is clear. The year in dual antiplatelet therapy, so it's the aspirin plus P2Y12. If you have an anticoagulant, it's only as maximum 1 month in triple therapy. And then after that, and that's in select cases, meaning those who they're discharged with DOAC and P2Y12, and that's for 1 year, and the rest of the time it's indefinite. And then they continue with the DOAC. Second point, and now we're going to talk about the agents to lower cholesterol and the objectives. Our most important agent and are the statins, and the way they work is that they inhibit the enzyme that you see there, the HMG, in the liver. And what that is, when they avoid the formation of cholesterol, and this results in more LDL receptors that come to the surface and can capture more. So there's an upregulation because it increases the number of LDL receptors that are at the where the LDL then goes down. Okay. One question that is frequently asked by patients is that they sometimes think that they're just starting the medications of cholesterol, as they call them, because their cholesterol is high. But sometimes the cholesterol or the LDL is maybe not that high. So they ask themselves, well, why are we starting them and what is the objective? And I tell them this, look, one thing is the number, and we want to bring down the numbers to this amount, and we will show you what those objectives are. But we want to bring down, for them, it's easier to understand this concept, but I tell them we want to bring down the probability that those cholesterol plaques that are already stuck within the veins and arteries break. We want to reduce the size, but the reality is that uh, studies tell us, including the Astro trial, the reduction of the size is very modest. So thinking that we're reducing the size of the plaque, we're actually stabilizing that plaque. We stabilize it because we make it less, we bring down the probability of it breaking down. So we bring down the necrotic core, that part that has lots of inflammation and necrosis. And then in this photograph, you can see, and it's like the mustard color. We want to reduce that in size because that is what breaks and what makes a plaque unstable. And the one to the side, we want to have a fibrous or a fiber layer that is thicker. And if it's thicker, it gives stability and avoids the breakage, and that the lumen gets liberated and brings about a thrombosis event. Okay, so tell them that the number is something, but we want an objective, but it's about avoiding the growth of the plaques and that they cease to be unstable. Every time you're going to start, I mean, this is the way I practice. The reality is that when I'm going to start a patient on statin, I will start them in one of these two, either atorvastatin or rosuvastatin, because they're the only ones that allow me to bring them up to high intensity. Since I don't want to be having them changing what's back and forth, and if I have a dose and then we don't reach our objective and have to go up, up, up. So, and we don't want that if we don't get the objective. So if patients cannot tolerate them, then you change them to something different, which is fine. But I would always start with one of these two, atorvastatin or rosuvastatin. The statins, these are the statins with the best cardiovascular outcome data. And of course, the statins are our first-line agents because they reduce the cardiovascular events. Let's keep going down. What are the objectives of LDL? And this is relatively new. These guides came out at the beginning of this year, maybe March of this year or so. So this changed. The objectives of LDL in cardiovascular events are either less or equal to 55 if the patient is at very high risk. And how do we define that? Well, it's a patient that has one of two, which is the beige little square, two or more major events of ACVD, like the ones you see there, a coronary event in the previous 12 months, a history of a myocardial infarction in the past, a history of ischemic stroke, or a for our theory, a symptomatic PAD incident. If they have two or more, or one of those major events with two or more high-risk conditions, then that means that patient is at a very high risk. And then our objective will be equal or less to 55 in LDL. If they only have one event, and this is the way I see it, even though we don't really define very well what high risk is, we're very well defined on at very high risk, but high risk, not so much. So if you have one of the majors or doesn't comply with the major but has a number of high-risk conditions, my goal will be to treat them as high risk and less or equal to 70. Okay, let's go forward. Okay, so if the patient does not tolerate statins, and I do have to say that in the secondary prevention setting, meaning 1 year after the event, an infarction, if the patient does not tolerate statins, we will immediately move to a PCSK9 inhibitor, and I'll explain it. If we were not in that scenario, 1 year after the infarction, we could try a statin, then another one, and we could give him, a month to watch between one. We could tell him to use it between 2 or 3 times a week. One day is when they know. But again, this slide is more as primary prevention, where we have a bit of flexibility of playing around with the statins. But in secondary prevention, they're much more aggressive. And if the patient does not tolerate statins, then we move them to a different medication like a PCSK9 and CETIA. It works at the intestine level. It works stopping the absorption of or inhibiting the absorption of cholesterol. This makes the receptors of the LDL increase. As a monotherapy, CETIA doesn't really do much. To give you an idea, a high-intensity statin tends to lower 50%, versus CETIA, which will just reduce about 18% of the LDL as a monotherapy. And with a statin, a maximum of 25%. That's the dosage. And we did see this in the GROOVIT trial, where adding CETIA to a statin after a non-acute event did reduce cardiovascular events. So if we see a patient that has a cardiovascular event and we increase a statin and he is in about 40 and the LDL is still in 78, we start CETIA. And ideally, we would want to start from the hospital and they're discharged this way. But if not, then we start them on it. Okay, let's continue. And here very important. Repatha, or evolocumab, is an monoclonal antibody that bind to the PCSK9, which are the ones in charge of degrading and decreasing the receptors, the LDL receptors. So if we do it, we see that there are less receptors of LDL on the surface. The indication for this medication is those patients that are already in maximum therapy in statins that they can tolerate, and their LDL is still below what they are expected to have, and those who cannot tolerate statin. So, and we're doing secondary prevention. If we start the medication because we don't reach the goal in the LDL, we keep the statin, and on top of that, then we add the PCSK9 inhibitor. With the Repatha, the reduction is about 45%. And the way it's given, it's subcutaneous, it's pre-filled, you inject it in the stomach, the thigh, the arm, every 2 weeks. You can go forward. You don't see it very well, but these are the guides. Thank you. The cholesterol guidelines of 2026. And these are patients that are at a high risk. What are we going to do? What I've been saying. Basically, we start with the statins. We expect that it will be reduced by 50% to reach the goal of 55. This is a very high risk. So we want them equal or less than 55. If we don't get there, we ask the Zetia. If not, if we still don't get there, or they don't tolerate the statin, then we go on to add a PCSK9 inhibitor. And the yellow ones that you see from here on down, I didn't talk about it, but there are other medications that we could start in case we don't reach the goal, even with Repatha, or if they don't tolerate one of the previous medications. Okay, the triglycerides. Patients with secondary prevention, we have the trial of Reduce It trial, where they saw that patients that had already had a cardiovascular event were benefited by adding cosapencetil 2 grams twice a day. This is Varsepa, known as Varsepa, because it reduces cardiovascular events in 2 groups. One, in patients who are diabetic, with whom we're doing primary prevention, and patients we are working with on secondary prevention that have triglycerides in 150 to 499. The first thing that we're going to do is still to bring the statin to the highest tolerated dose. There is a reduction in the statin. The statin reduction does reduce triglycerides, not very much, but it does. And then we have to check on these changes in lifestyle and so on. But if he doesn't improve, then we start with Varsepa. And it has to be with that dosage, because that's the one where the studies identified that there was a reduction of cardiovascular risk. And that study is very interesting, even without, triglycerides will go down, but even without having a marked reduction in triglyceride, but the events went down significantly. Can you go back a little for a second? There's something that's very important that I tell my patients, and I tell them at once, even further.
For them to take the medication with food and to put it in the fridge because it smells like fish. And when they burp, it tastes like fish. So please explain that to them, because many times, for them to know that this can happen, it empowers them of what's going on. And they feel comfortable and they dare to continue treatment. So if you're going to choose a medication to reduce the triglycerides, it will be Varsepa. Okay, let's continue. In combination with the statin. In this slide, you can see it very well, but this is what I've described. first thing we're going to do is identify the secondary causes of hypertriglyceridemia and how to manage them, and then maximize the statin dose. And after that, if the patient continues with triglycerides above 50 but less than 500, then what we're going to do is right here, we're going to add Baxepa. 2 grams twice a day for a total of 4 grams daily. Next slide, please. If the patient has severe hypertriglyceridemia, more than 500, that's when we have the fibrates. The between 50 to 499, they're not the primary defense. Why? Because icobenzapyl, it does have a reduced risk of cardiovascular risk, but this is the second line of defense, or when it is above 500, and we have this alternate that we see here, fenofibrate, fenofibric acid, which is trilipid, and we have lopid, and we try not to use them. The lopid, we will not try to use them because it has a lot of interaction with statins. And with these medications, we expect a TG reduction between 30 to 50%, but we have not seen a reduction of cardiovascular risk with this type of medication. So we spoke about antiplatelet therapy, cholesterol therapy, and the goal is same or below 55 on high-risk patient or very high-risk patient, and 70 correspondingly. The triglycerides, if they're still high, even though they're on optimal statin dose, then the next step is Baxepa. If with a high dose of statin, still the LDL is not reaching those goals, 55 or 70 correspondingly, the next step is to add ezetimibe. If you're still not reaching the goal, or the patient can handle well statin, then the next step is evolocumab. But now we go to the third pillar, and these are cardioprotective medications. And the cardioprotective medication, and they're broken down into 4 areas. This first one are the ACE inhibitors and the ARB family. Now, not everybody has to be on them. They're cardioprotective medications, but only for a specific group of patients. And these are the ones that have an acute cardiovascular event and that have hypertension or diabetes, or they have a blood pumping level less than 40, chronic liver disease, or a interior location. But many patients that have one kind of these have these kind of things like hypertension, renal disease, diabetes. So they will benefit from being on an ACE inhibitor or an ARB. Now, the MRAs on the right side of the slide, they are prescribed after acute coronary event with patients that have an LVEF less than 40% and diabetes or heart failure symptoms. And this is to reduce all costs and death. But the third group of cardioprotective medications, and this one is very interesting, these are the beta blocker. And historically, it was thought that they were cardioprotective medications, and they are in a way, but in a very select group of patients. And these are in patients with an LVEF less than 50%, and patients that in the post-op or the post-incident, they have evidence of ventricular arrhythmias. But in 2024, there was a reduced AMI study in 2024 in which they noticed that patients that were on beta blockers and that they had the preserved function on the LVEF, they did not see any reduction in cardiovascular risk or death with the use of beta blockers. And this is because these therapies, when they were tested or when they were first used, the beta blocker, they were done way before the development of the modern antiplatelets or the modern revascularization. So they redid the studies to see if it was true, and it turned out that the benefit to keep a patient on beta blockers after a year from the cardiovascular event, it is untrue. It is unneeded. And it should only be kept patients on those medications if they have any other kind of indication, whether it's angina, arrhythmia, or hypertension. And I can see here from the guides, you see no benefits. So that in patients with CCD with a previous MI or LVEF under 50%, the use of beta blocker only because historically we used it a lot. There is no benefit and there's no indication to continue to keep them on that therapy. Usually what I do with patients that have had an acute coronary event, if you don't have any other counterindication, if the pulse is stable, they don't have any first grade blockage or any kind of blockage, I keep them on a year of therapy, and then we would reconsider if it's needed to continue with that beta blocker. And if not, we just, take that off from his prescriptions. Now, the fourth group, and I had shown this before, but this one's also very important. And here, we have to be very proactive to identify who can benefit from the SGLT2s, but patients, for example, that have diabetes with some kind of established cardiovascular event, they will benefit if we put them under. So patients with renal failure, with kidney disease, we'll be doing secondary prevention. Patients with multiple risk factors, which would be primary prevention. Or the fourth one, which is chronic kidney disease. There's our patients that should be on the SGLT2s, which are dapagliflozin or empagliflozin. And the third group, the anti-anginal medications. We spoke about the CCB. Now, the anti-anginal medications are the calcium channel blockers, the beta blockers, the nitrates, and ranolazine. And they're really in an order. We shouldn't be started first, but it will depend on if we have used a medication for an arrhythmia, then we will maybe start on a beta blocker on our CCB. If there's another comorbidity, we would choose which institute we can add then the one that would do function from these. But patients that, for example, have a cardiovascular event, we will not use CCB if a patient has systolic dysfunction of the left ventricle. The CCB is the first line of defense for vasospastic angina. And usually this is a diagnosis that looks like a acute coronary event, but there's no obstruction evidence. And in those scenarios, that should come out like so in the report. And in those cases we see like that, the CCB is the first line of defense. And see him here, verapamil or glutathione. Glutathione is generally better tolerated than verapamil. Then the beta blockers The more commonly prescribed are metoprolol succinate, which is Toprol. And you see here on screen the doses, 25 milligrams to 100 milligrams, and carvedilol, which is correct. And it does have uh, a blocking. It's usually then on the combination of baby and the CCB, it is not as common, and they're used with caution because they could exacerbate bradycardia if you have the beta blockers and the calcium channel blockers. Now, the third one, which is ranolazine, this would be the third one that would be added, and I'll show you in the next slide how, but it's usually the last one that we would add as an anti-anginal medication. Now, we can start at 500 milligrams twice a day, and we can continue to optimize that dosage up to maybe 1,000 milligrams twice a day. And of course, we got to look at any interactions with other medications, especially, with like SSRIs, because again, with a combined therapy, uh, we can see a prolongation of QT. So the reality is that you could choose the anti-anginal therapy in any sequence. You could either start with a beta blocker, then in the next box, you could add the nitrates, then in the next box, if the patient is tolerating and you have a low risk, you can add the calcium channel blocker. I usually don't combine with the beta blocker with the calcium channel blocker. Normally, I wouldn't combine them. The CCBs, verapamil or diltiazem. I normally go from beta blocker. Now, if it's a younger patient, let's say a patient that has had a acute coronary event and they're 40 years of age, they don't have any systolic, any LV dysfunction, I usually want to start them with the calcium channel blocker to prevent the ED secondary effect that we see with the beta blockers. So I started with the calcium channel blocker, then I added nitrate, and then from there I go to ranolazine. Now, in that process, I could prescribe sublingual nitroglycerin for patients that have refractory episodes, even though they're in an anti-anginal therapy. Remember that nitrates are contraindicated on patients that critical aortic stenosis and also hypertrophic obstructive cardiomyopathy. But for patients that the chest pain is not too frequent, maybe once a week, I would rather give them sublingual nitroglycerin, and I explain to them, only when necessary. But if I see that the chest pain is more recurrent, I change it then to maybe once a day. Now, the blood pressure, the target is less than 130/80 to reduce cardiovascular events. These are the preferred agents. You see them here. On screen, ACE, beta blockers, thiazide. I'm going to explain to them, look, you're going to measure your blood pressure. If not daily, 3 or 4 times a week. And that way, they figure, it's not that often, but it is enough to have a good average, which is what we want. And let me show you this slide because this is an article from a paper that recently came out in May of this year, and it's very interesting and also very alarming, which is, and what this graph shows is how successful we have been to keep the targets on cholesterol and pressures for secondary prevention. And it's not that we have bad medications. We have really good inventory or toolkit, but our system doesn't help us to reach the goals and the standards that we need. And if you can see here in the left column, only 17% of all patients achieve the target of LDL less than 55. So we definitely have a lot of room for improvement. And we will tell our patients in regards to physical activity, same thing. After the cardiovascular events, their concern is when. when can I start? How should I start physical activity? And normally these patients should be going to a cardiorespiratory therapy where there's a center that will take them little by little, to see some stress tests. There'll be a physical therapist with uh, uh, all that kind of personnel. But in Puerto Rico, we don't have this type of rehabilitation center. So our responsibility is to at least guide them how. So the guides say at least 150 minutes a week of moderate intensity. You're walking, you could be talking on the phone, you're at the right intensity. If you're walking and you're struggling a little bit, that is, you know, a higher intensity, and that's 75 minutes. And you're going to do this in a way that you can tolerate it. Of course, at the beginning, your cardiovascular resistance won't be optimal. It's not the best one, but you're going to go step by step. If you have, uh, shortness of breath, palpitations, you decrease the intensity, and you can't, and them not to start, every day the first week. They can divide it, maybe do 20 minutes today, 15 minutes tomorrow, and so on. And before we give them the okay, I usually do a stress and test to have that information of that, cardiovascular risk. We know about the nutrition recommendations. An ideal recommendation is like a Mediterranean diet. We don't need extreme TikTok diets. In my mind, what I think we have to do is common sense. Diet, that the best source of protein is fish because, those have the best kind of omega 3s, and we need that to keep our cholesterol low. Also, vegetables, root vegetables, nuts. If you like chickpeas, for example, those are good. And at the same time, reduce intake of right stuff, processed foods. And this information comes from the study, which is the PREDIMED trial. And what we see here is that the diet, uh, as early as a year, the benefit on those patients that followed the diet was huge. So if we start to do this a few months into it, we can see a reduction in cardiovascular risk. And the longer we do this, the more we reduce that risk of another cardiovascular event. And we need to identify on those that smoke, if they're smoking, how much they're smoking, so that we have to be creative with them and, even get to pledges, that if they can reduce from a pack to half a pack. I mean, I ask him, I'm at what time and what brand and why, because that's, when I drink my coffee, I tell him, well, why don't we not smoke the one before you go to sleep? So we kind of, work with them, we get for alternatives with them because, it is an addiction and it is a hard addiction to kick. It creates a habit, and when they go to smoke, there's a habit, there's a routine. So it's important to speak with them about this. So the medications that varenicline, or if not, bupropion. Now, next slide. And they can be combined with an NRT. This is over the counter. This is the nicotine replacement therapy. I mean, it is uh, costly. The patch is like $50, lasts for about 2 weeks. Maybe comes out the same as buying a pack of cigarettes or buying the pack of cigarettes. And it should be two replacements. So if they add the patch and you tell them, well, you can also buy the gum, the nicotine gum, and if you can see an example. you have the daily patch, and there's a patch for the first week, second week, the fourth week, and the fifth week, and the amounts are being reducing, and then you combine it with nicotine gum if you have any cravings, and you take as many as 4 pieces a day, and then that combined nicotine therapy gives better results. Now, alcohol use for men, the recommendation is less than 2 drinks per day, and in women, 1 or less. There is no reference to see which is better, if wine is better or beer is better or hard drinks, or which one is worse. There is no data on that. What we have seen is that binge drinking, and that's 50 or more grams of alcohol in a single occasion, which is about 4 drinks for normal drinks, that is associated with higher mortality rates. And normally when people ask me, I tell them, look, there's no data that says wine is better than beer or hard liquor, but I can tell you that if you're combining a hard liquor drink, let's say whiskey with something, there's more calories in that drink with whatever you're adding to it. Maybe it has more sugars. I usually tell them, if there's one, drink wine, for example, but there's not that if one is better than the other. Now, the question that we also get a lot is sexual activity, and is when can I go back to having sexual activity? We need to wait at least a week. Sexual activity is equivalent to walking or climbing 2 flights of stairs, and it should be at least a week of waiting. Although we're seeing that sexual activity is the cause of less than 1% of all acute cardiovascular events. Definitely, if the patient still has unstable chest pain or a lot of symptoms, severe symptomatic, we definitely tell them to defer sexual activity. Now, if the patient is going to use something like sildenafil, which is Viagra, or tadalafil, which is Cialis, they can't use nitroglycerin, and they have to avoid the nitroglycerin for 24 hours if it's Viagra, or 24 and 48 hours if it was Cialis. For patients that have CCD, especially with doing secondary prevention, I would rather give them sildenafil, which is Viagra, because the life of that medication is less. So if they have chest pains the next day, they could go back and take the nitroglycerin. But it's very important for them not to combine nitroglycerin with any of these 2 medications. It could definitely bring down their blood pressure too much. And the last thing that I wanted to share with you is that patients that have had a CCD, 20 to 40% of them develop or have depression and anxiety. And these cardiovascular events are tied to higher incidence. So we need to ask them. And if we identify, so we need to screen positive for depression, and we need to refer them to a psychologist or a psychiatrist. So, in summary, dual antiplatelet therapy for 12 months as a general rule. Now, LDL less than 55 milligrams in very high risk patients, the ACE inhibitors or the beta blockers as cardioprotective therapies when indicated. SGLT2 for patients that are have diabetes or CKD. Blood pressure needs to be less than 130/80. The diet should be a Mediterranean diet. Also, smoking cessation, and to recommend for them 150 minutes a week or more of moderate aerobic exercise. So these are the references, and this is the end of my presentation. Thank you. Thank you very much, Doctor. This is excellent as always for the participants. This is, we have a Q&A session now. We have about 4 minutes to be able to ask any questions. If there was anything that you guys would like to ask for. Now, I also wanted to just as you see on your screen the post test. So far, we don't see any questions. I really hope that this has been very educational, very with a lot of great information, a great session. We have definitely learned a lot about a lot of things in this series. We will keep the post test open. And now I will leave you with the satisfaction survey. And I know that they're on screen, but also on the chat. And these are our next webinars. You see them here on screen. We have billing process and reimbursement for telemedicine. This one will not have CCEs, but the next one, which is on June 25th and June 26th, they will have CCE with Gabriela Tirado, and the topics are additional intervention in primary care. And the other one on the 26th, it will be practical strategies and referral criteria. I will go now so you can scan the satisfaction survey. Norma? Good afternoon to all of you. I did have a question for the doctor. Is she still there? Yes, she is. What is the best time during the day to take the statin? Historically, yeah, but I still haven't researched into why. But pharmacists normally recommend to take it in the afternoon. And that's usually what we see now to take it in the afternoon. But when we look at the guides, we don't see it as a super relevant point that it has to be in the afternoon. Um, we don't see that in any of the secondary prevention guides or primary prevention guides. So what I tell the patient is this: historically, you take it in the afternoon. That's where you see it in your prescription. That's what the pharmacist will tell you. If you're going to take it in the afternoon, that's fine. If the time in the day where easier for you to take him is in the morning, take it in the morning. What I prefer is for them to take it. Doesn't matter when in the day. The important thing is that they actually take him versus not taking the medication. Thank you, doctor. Thank you very much, Norma, for the question. It appears that the satisfaction survey link is not opening, but it is now in the pop-up in your screen, so you can see it there. So we will keep it open. And we thank all of you for being here and for being committed to being with us this hour. We will see you guys in the next session. And Doctor, thank you for always being present and really the wonderful presentations, really good presentations, Doctor. And the doctor also has an Instagram. Doctor, if you want to give everybody your Instagram. Yes, that's where I also put my tips is cardiologia.mars. Thank you for inviting me, and I'm always at your service. Thank you very much, Doctor. And to the participants, our survey is still open. Those that answered it can, disconnect. And thank you very much to all of you.